Good morning. My name is David Murray. I am the Associate Director for Prevention and the Director of the Office of Disease Prevention at the National Institutes of Health. I'm pleased to welcome you to the 2020 ODP Early-Stage Investigator Lecture. We created this lecture several years ago to highlight early career prevention scientists who have not yet served as a principal investigator for a substantial NIH-supported research project, but who have made outstanding research contributions to their respective fields, and who are poised to become future leaders in prevention research. Before we begin, I have some housekeeping items. You can submit questions during the webinar by clicking on the chat box in the lower right-hand corner of your WebEx window. Please direct your questions to all panelists. We will open the floor to questions at the end of the lecture. The slides and video recording will be posted on our website in approximately 1 week. You will receive an email when they are available. Our speaker this morning, our 2020 ODP Early Stage Investigator Awardee is Dr. Julia Marcus. Dr. Marcus, who was just promoted to Associate Professor, is an infectious disease epidemiologist at Harvard Medical School and Harvard Pilgrim Healthcare Institute. Her research focuses on improving the implementation of pre-exposure prophylaxis, or PrEP, for HIV prevention. Dr. Marcus has led studies that are cited by the Centers for Disease Control and Prevention as key evidence of the real-world effectiveness of PrEP, and by the Infectious Diseases Society of America and the American Association for the Study of Liver Diseases in support of hepatitis C virus screening for PrEP users. She has pioneered the use of machine learning with electronic health record data to identify potential PrEP candidates in healthcare settings, an approach that is now the basis for multiple implementation projects across the country. Her work has been funded by several NIH institutes, including the National Institute of Allergy and Infectious Diseases, the National Institute of Mental Health, and the National Institute on Minority Health and Health Disparities. Dr. Marcus will speak with us today about her research on strategies to improve PrEP uptake, including the use of electronic health records to help healthcare providers identify patients who may benefit from PrEP. Please join me in welcoming Dr. Julia Marcus.
Thank you so much, Dr. Murray, for that introduction, and thank you to the Office of Disease Prevention for this award and this honor. And I'm really excited to have the opportunity to share some of my work with all of you today. Normally I end my talks with the acknowledgements, but this time I want to start with a few acknowledgements. I want to first acknowledge the amazing mentors I've had throughout my career. These are all infectious disease experts and leaders in the field who have experience in different settings: academia, government, a hospital setting, a community health center. It's kind of a diverse group that has really informed my training and has supported me throughout the years. So I want to just express my gratitude for them because they are really the reason I'm here. I also want to acknowledge the NIH. I have benefited for the last 5 years from NIH support, starting with a loan repayment award from NIMHD, and really notably a K01 Career Development Award from NIAID that initially focused on HIV and hepatitis C co-infection, and then really evolved in scope to focus more on PrEP as I switched institutions. And now I'm the co-PI of several projects funded by NIMH and NIAID that are focused on PrEP, and I'm going to be talking about these throughout my lecture today. And now also a co-investigator on a more recent grant focused on implementing COVID testing for vulnerable populations in Massachusetts. So what I want to talk about today first is kind of a broad overview of PrEP for HIV prevention and sexual health, and I'll give you a sense of where my work has fit into the field. And then some work on mitigating barriers to PrEP implementation. My work has evolved over time as I've been working on PrEP for quite a while. Starting with initial questions about real-world effectiveness and safety, and now much more focused on implementation science. And you'll kind of see that as I'm going to tell a story beginning with when PrEP was initially approved and all the way to today. So I actually want to go back even further just for a minute, just to bring some perspective into this talk. This is a report from 1981 on rare cancers that started to be seen in gay men. And this was before HIV was even identified as the cause of AIDS. And, you know, there was a lot of fear and confusion at the time, and a lot of also really shame-inducing and fear-based public health messaging. Reputation isn't all you can get from sleeping around. And I show this both to give perspective on how far we've come to what I'm going to be showing you today, but also to give you a sense of the kind of messaging that has perpetuated some of the stigma that remains a major barrier to ending the HIV epidemic and has come up quite a lot in my own research. I'm going to talk today mostly about HIV prevention, but I want to just quickly mention HIV treatment, which has really undergone a revolution over the past few decades. And some of my work has focused on the long-term outcomes of HIV, including life expectancy, which has changed dramatically over time. So I want to just give you a little snapshot here before I move on to talk about prevention. I'm going to show you some data on changes in life expectancy for people with and without HIV at Kaiser Permanente, Northern California, a large healthcare system. And first, you can see this is the mortality rates for people without HIV from 1996 to 2011. This blue line is basically flat. And then in contrast, the mortality rates for people with HIV dramatically declined from 1996 to 2011. And when we look at the corresponding life expectancies, or the expected years of life remaining at age 20, we see they remain in the blue dots fairly flat for people without HIV. And again, this really dramatic increase in life expectancy for people with HIV. So in 1996, somebody with HIV was expected to live to age 39, given survival to age 20. And that increased to age 73 in 2011. And I actually get chills every time I see this graph because it's just such a remarkable testament to the progress in this field from the time I was in high school to the time I was in my PhD program. And we don't often see progress like this in infectious diseases. And so it's really an incredible development. And these same medications that have been used for treatment, as it turns out, can also be used for prevention. And this was the first trial to show that that was the case, that antiretroviral medications were effective in preventing HIV infection in people who were at risk of acquiring HIV. And in this case, it was men who have sex with men and transgender women in a multinational trial called the IPREX study. And they found a 44% risk reduction for tenofovir emtricitabine or TDF-FDC PrEP compared with placebo. And this trial came out the year I started my PhD program, and I had previously worked in this lab before getting my MPH on some of the formative work for IPREX. And so when this came out, I was really excited to go back and do research in this lab with some of these data because it brought up some real world questions translated into clinical practice. And I'll talk about some of that research in a few minutes. Those real-world effectiveness and safety questions were the focus of some of my postdoctoral research at Kaiser Northern California, where we looked at early adopters of PrEP in clinical practice. There were a lot of concerns that PrEP was going to be less effective in clinical practice than it was in clinical trials. And of course, that 44%, while it was a game changer, it's not as high as you would want to see, let's say, for a vaccine. It turned out that when the IPREX investigators looked at people who were actually taking the medication regularly, effectiveness was much higher. But still, there was a concern that when people didn't have the adherence supports that they had in clinical trials, we would see even lower effectiveness in clinical practice. And actually, we saw the opposite. So we looked at Kaiser at the first 1,000 or so PrEP users and looked at their incident STIs and HIV during their first year of PrEP use. And we saw these very high rates of STIs, with 42% of PrEP users having an STI in the first year and 27% having a rectal STI, which is a marker of condomless anal sex. Yet, despite all that exposure, no HIV infections. And every time we continue to update the data and add more person years, we continue to see no HIV infections in people who were regularly using PrEP. And even today, we still only have a handful of published HIV breakthrough infections in people who were consistently taking PrEP. And this study, even without a control group, was such it was seen as such robust evidence of the effectiveness of PrEP given such high levels of STIs with no HIV that it really lent confidence to the translation of PrEP from clinical trials to clinical practice. And now, on the basis of our research from Kaiser and from demonstration projects, the CDC estimates that PrEP is 99% effective in reducing the risk of HIV acquisition in men who have sex with men and heterosexual men and women when it's taken daily, and 74 to 84% effective in people who inject drugs for whom there is less robust evidence and unfortunately has been lower uptake to date. So, we now have this intervention that is 99% effective in preventing HIV acquisition. And I'll also mention that HIV treatment is a highly effective prevention intervention as well. We now know that people who are virally suppressed on treatment cannot transmit the virus to others. So, at this point, we should be seeing some pretty dramatic declines in HIV incidence at a population level. And we're not yet seeing that. And we wrote this editorial earlier this year with David Paltel and Rochelle Walensky on a study that had suggested that there may be some population level benefit of PrEP, but we thought the jury is still out. We're seeing nationally a plateau in new HIV infections at about 38,000 per year, and that's since 2014, and that's despite PrEP and despite treatment as prevention. We do see declining HIV incidence in some subgroups, particularly among white MSM, men who have sex with men, who are the most likely to be taking PrEP. And so that's suggestive that maybe PrEP is having a population level impact within certain subgroups that have had high uptake, but not others. And the study that we were commenting on did provide some evidence that states that were in the highest quintile of PrEP coverage had a greater annual % decline in HIV diagnoses. And so that's promising, but it was a small association, and there are a lot of reasons why we couldn't really conclude a causal effect of PrEP on HIV incidence at this point. And so I'll just mention here that this is one of the research questions we're exploring in an R21 funded by NIAID. This is a collaboration with a biostatistician who has expertise in causal inference methods. And we're using electronic health record data from multiple clinical practices in Massachusetts to try to understand the effects of increasing PrEP uptake on not just HIV, but also bacterial STIs among men who have sex with men. So even if PrEP is not yet having a robust population level impact, we also know that it has other important benefits. One benefit is that it provides an opportunity to intervene on STIs. STI screening is an important part of the PrEP care package. PrEP users are screened at baseline and every 3 to 6 months for STIs. And in this mathematical modeling study led by my colleague Sam Jeunesse at Emory, he found that frequent STI screening and treatment during PrEP use could actually decrease STI incidence among men who have sex with men. This graph is showing STI incidence by the screening interval for PrEP users, and that top yellow line is PrEP users who were screened every year, and all the way down to the purple line at the bottom where PrEP users were screened every month. And of course, the reality is somewhere in between, but in every scenario, we see an expectation that STI incidence will decrease at a population level. And so again, this is a question we're exploring in our R21 using causal inference methods. And this is also the subject of a project that I'm on with Sam Jeunesse that was recently submitted to NIMH called STIRUP. And this would be expanding on some of this prior mathematical modeling work using the EHR data from our R21 from Massachusetts to try to understand what the optimal STI screening policies are for PrEP users, particularly for men who have sex with men. In addition to HIV and sexual health, PrEP does have other benefits, and some I won't be going into detail here today that are really from the perspective of the PrEP user around their reduced anxiety, sexual satisfaction, and a number of other sexual health benefits. But I also want to mention the ways that PrEP may engage people in primary care. We looked at this at Fenway Health, which is a community health center here in Boston that specializes in care for sexual and gender minorities, and they're the largest PrEP provider in New England. And we looked at people who were eligible for PrEP in the sense that they had had a rectal STI test. And so that's suggestive that they had reported to their provider that they'd recently had condomless anal sex and therefore were a good candidate for PrEP. And of those people, we looked at those who had received PrEP in blue and those who had not received PrEP in orange. And the PrEP users, in fact, were more likely to receive other types of primary care services, including flu vaccine, more likely to be screened for tobacco use, more likely to be screened for depression, and more likely to receive glucose testing, which can be used for diabetes screening. And these associations were somewhat attenuated, but still held when we adjusted for a number of visits that people had. And this was a cross-sectional study, so it may be that PrEP is engaging people in primary care. It might also be that people who are motivated to care for their health are more likely to seek out PrEP. So we followed this up with a mixed method study where we did some qualitative work, did some interviews to understand what was going on here. And we did in fact see some of these themes come up where people reported PrEP being a reason that they established a relationship with a primary care provider, and PrEP kind of naturally evolving over time into other primary care services. So, for women who tend to seek out family planning services, there's a reason to engage in primary care, whereas in this case, men who have sex with men are the majority of PrEP users at this point, and they may not have other reasons to seek out primary care. So this may be one way that they're engaging with the healthcare system. So now I want to talk about some of the barriers to PrEP implementation and some strategies to mitigate those barriers. And there are numerous barriers, and I'm only going to be talking about a few here today that my research focuses on. But this really is the main, I think, area of research for PrEP now, is trying to understand these barriers and mitigate them to achieve real population impact and equity. So I'll take you back to this article that came out the year after FDA approval. This was in 2013, asking, why is no one on the first treatment to prevent HIV? And of course, we've made a lot of progress since then, but not as much as we would have liked. There are now an estimated 1.2 million Americans who have indications for PrEP, but only 18% of those used it in 2018. So we're reaching about 1 in 5 people who could benefit. And so that starts to be the first hint of why we're not seeing this robust population level impact at this point. In addition to that, it's not just limited uptake, it's inequitable uptake. PrEP is used least by people who need it most. This is perhaps the most chilling statistic in the HIV epidemic in the US. The lifetime risk of HIV diagnosis among African-American MSM is estimated to be 1 in 2, 1 in 4 for Hispanic MSM, and 1 in 11 for white MSM. And when we try to map PrEP coverage onto these groups, we actually see that it's inversely correlated. The lowest PrEP coverage is among Black individuals in the US who are likely to benefit from PrEP. And the highest PrEP coverage is among white individuals who are likely to benefit from PrEP. And so we see this mismatch between need and uptake. I'll also mention that we see these disparities in PrEP use even in insured populations. And so this isn't just explained away by differences in access to care. And we looked at this at Kaiser Permanente, which is not only a healthcare provider network, but also a health plan. And so everybody who is a member has access to healthcare, although they may have different health plans within that. And we saw that people who had recently contracted HIV were far more likely to be Black, Latinx, and under age 30 than those who were actually using PrEP. And this was particularly stark in the sense that 24% of those who'd recently contracted HIV were Black, compared with only 4% of PrEP users. And so obviously it's not access to care that is explaining these disparities, although it may contribute. And there are many other factors, including stigma, structural racism, which is pervasive and has effects at the patient level, the provider level, the system level, cost, and I'm going to talk about a few of those today. We explored this a little bit further at Kaiser to try to understand better what the barriers to PrEP use were for these people who had recently contracted HIV. We actually surveyed them with several hundred people and asked, why were you not taking PrEP before your HIV diagnosis? And these were people who'd had a recent negative test and then a positive test. So we knew that they had actually recently acquired infection. And we got a range of responses. First, half said they just didn't know about PrEP before their HIV diagnosis. And this was several years ago, so my hope is that this proportion would be lower now. But we do know that awareness is still an issue, and particularly for some subgroups more than others. Even among those who were aware of PrEP, we saw a number of barriers, and I'm going to focus on a few. The most common were cost, or not having adequate insurance coverage, and believing themselves to be at low risk for HIV. There was another commonly reported barrier was not wanting people to think poorly of them for taking PrEP. And so these are 3 barriers that I want to talk about a bit more: stigma, cost, and the challenges of HIV risk assessment, both for the patient and the provider. So first, I'll dive into stigma. I think one of the best ways that we can encapsulate the stigma around PrEP is with this concern about risk compensation. This is the idea that people who are given access to a prevention intervention that reduces their perceived risk will compensate by increasing their risk behavior in other ways. And this comes up around all sorts of interventions. There's a concern that people who wear sunscreen will spend more time in the sun, that people who wear seatbelts are going to drive more recklessly. It tends to come up the most around sex and drug use. And, I'll give a few more examples. Let's say the HPV vaccine, there's been a lot of concern that teenage girls who receive the HPV vaccine are going to have an earlier sexual debut. In the case of PrEP, there have been a lot of concerns that if people start taking PrEP, they're going to reduce their condom use. I'll also mention that this has come up, this may sound familiar to you, around mask use during the COVID pandemic. There's been a concern that masks would give people a false sense of security and they would socially distance less. So, does this happen? Does risk compensation happen? It certainly happens at an individual level. It's a phenomenon that exists. But does it happen on a population level? And by that I mean, are there examples where where behavior change is so great due to a prevention tool that the benefits of that prevention tool are actually negated by the behavior change? And I can't think of any examples where that's actually happened, but this concern continues to be raised. So this concern about risk compensation was really prevalent around the time that PrEP was approved. And this is a photo of Michael Weinstein from the AIDS Healthcare Foundation at the FDA Advisory Committee hearing about PrEP, which I actually attended in 2012. And he's probably the most vocal anti-PrEP advocate out there. And you may be wondering why somebody from an AIDS Healthcare Foundation is anti-PrEP, and that's the topic for a different talk. But he had brought a bunch of clinicians from the AIDS Healthcare Foundation to flood the public comment period with concerns about risk compensation. And they called it a party drug. They said condoms are the mainstay of HIV prevention. We should not put PrEP out there into the world because it will replace condom use. And it's essentially a party drug. And this really culminated in this phrase that came out in the Huffington Post later that year, Truvada whores, which thankfully was eventually reclaimed by PrEP users. But you can see the stigma that was attached to this drug from the very beginning. And I'll point out this quote from my colleague at the time, Susan Buckbinder at the San Francisco Department of Public Health. She said, "We're not asking whether people who are on statins are eating more ice cream." And she's right. These concerns about risk compensation tend to be driven by stigma that's attached to what people perceive as irresponsible behaviors. So we actually looked at this in the IPREC study, and this was part of my doctoral research. And we wanted to understand whether risk compensation had happened among trial participants. And of course, a clinical trial is not the best place to estimate what kind of behavior change is going to happen in the real world. But they had asked a question of participants about what treatment group they believed they'd been assigned to. Did they think they'd been assigned to the active drug arm or the placebo arm? And some people said they didn't know. Some people thought they'd been assigned to one group or the other, and it wasn't correlated with what group they were actually assigned to, so we knew the blinding had worked. And our hypothesis was that if risk compensation were happening, the people who believed they'd been assigned to the active arm would have an increase in, or have a decrease in condomless sex throughout the, an increase in condomless sex and an increase in the number of partners they had throughout the course of the study. And we actually did not see that. I'm showing you in this graph the mean number of receptive anal intercourse partners over time by perceived treatment arm, and the red line is the placebo arm, the blue line, or the people who believe they were in the placebo arm, and the blue line is the people who believe they were in the active PrEP arm. And there's this decrease in the number of partners in both groups. And we saw the same thing for condom use. The condom use actually increased over time in both groups, at least reportedly. And what was interesting here is that we saw these curves were separate at baseline, which meant that the people who believed they were in the active arm actually had higher risk before getting into the study. And so it actually seemed to reflect more wishful thinking, that people who had higher risk were more likely to believe that they'd been assigned to the active arm. I continue to look at this in my postdoctoral research, and there's now a whole body of work trying to explore risk compensation by looking at STIs among PrEP users. And we looked at this in Kaiser Permanente patients, and again, this was the first 1,000 or so PrEP users at Kaiser. And we did see a couple of STIs, rectal chlamydia and urethral gonorrhea, that increased over time among PrEP users. And we didn't see that for some other STIs we looked at. And there's a lot of methodological questions here about what this actually means. Increasing STIs could reflect risk compensation in the sense that they may reflect decreasing condom use in PrEP users. They may also reflect a decrease in condom use in the community, which we know was already happening among men who have sex with men before PrEP was introduced. And they may reflect appropriate PrEP prescribing. We actually want PrEP to be prescribed to people who are at high STI risk. And for people whose risk changes over time, let's say they end up with a monogamous partner, it's appropriate for them to discontinue PrEP. And so we may see those people drop out over time and see the people who have continued exposure remain on PrEP, and we may see this increase in STIs as a result. I do want to point out, though, that the concerns about risk compensation are not just about STI risk. My colleague Sarah Calabrese has done some really amazing work measuring the biases that providers have around PrEP and really capturing some of this stigma and how it plays out in clinical decision making. She did a study where she talked to med students and asked them who they would be willing to prescribe PrEP to, and gave different scenarios of different kinds of patients. And it turned out there was this prevention paradox where they were least inclined to prescribe PrEP to the patients who needed it most. So those who said, I'm not using condoms, or I'm planning to discontinue condom use, or I have more partners, those were the people who med students said, I'm least likely to prescribe PrEP to this person. And she also found that was compounded by racial stereotypes. So med students were most likely to say, I think risk compensation is going to happen for a Black patient more than other patients. And so there ended up being this sort of intersecting stigma effect where Black patients with the highest behavioral risk were the least likely to receive PrEP, based on what med students said they were most likely to do in terms of their prescribing behavior. And so now it starts to become clearer why we aren't seeing this population level impact when we have these biases that are playing out in clinical care, such that the people who most need PrEP are the least likely to receive it. She also went a bit further and asked them what they thought were acceptable reasons for discontinuing condom use while taking PrEP. And she found that about 2/3 of conception was an acceptable reason. So this is where in a heterosexual couple, one person has HIV and they want to conceive, and they can take PrEP during that time period. And in contrast, very few said that intimacy, pleasure, or sexual functioning were acceptable reasons for discontinuing condom use during PrEP use. And these were correlated with somebody's willingness to prescribe PrEP. And so again, you can see how this can play out in clinical practice with a heterosexual couple being preferentially prescribed PrEP, whereas men who have sex with men are not prescribed PrEP because these reasons are not deemed acceptable for discontinuing condom use. This kind of culminated in a perspective piece in the New England Journal last year with Sarah Calabrese and my colleagues Ken Katz and Doug Krakauer on risk compensation and how it impacts clinical decision-making around PrEP. And we made an analogy, which others have made as well, to birth control, and went back to the early days of birth control when some of these same concerns were brought up, that oral contraceptives were going to cause sexual anarchy. And we don't see those concerns anymore for the most part. People access birth control, and there's an expectation actually that may be correlated with reduced condom use. And so people are provided STI screening and treatment as appropriate, and education around how to prevent STIs. So we argued that, in fact, that's exactly what needs to happen for PrEP, and that we shouldn't have to wait 50 years for it to happen. It needs to happen now. And we also pointed out that STIs are not the only thing that matter to patients. Patient-centered care requires recognizing that disease prevention may not be the most important health outcome to patients. And this is actually codified in the World Health Organization definition of health and of sexual health specifically, that it's more than the absence of disease. Actually a complete state of physical, social, and mental well-being. And so our most effective public health messaging and policies and clinical care is going to recognize that disease prevention is not the only aspect of health that patients care about. And I'll just mention here, Doug Krakauer and I are working on the early stages of an R34 that would be aiming to reduce stigma and increase PrEP prescribing among resident physicians, specifically in the South, where we see the greatest unmet need for PrEP. And the idea here, the sort of long-term vision, is to not only ensure that emerging primary care providers are ready to prescribe PrEP, but also that they are willing to prescribe it to marginalized populations who experience the most stigma and are in the most need of PrEP. All right, so I'm just going to briefly talk about cost and then go into the last barrier, which is HIV risk assessment. PrEP has been a very expensive medication. It costs about $2,000 a month, and this has been one of the barriers to PrEP scale up in the U.S. Truvada, or TDF-FTC, which was tested in the IPREX study, was the only medication available for PrEP until last year. And the way that it has played out is that insurance typically does cover it, and so patients are not paying much out of pocket for the medication itself for the most part. And there are also statewide assistance programs and an assistance program provided by the pharmaceutical company Gilead to help patients cover the costs of PrEP. What's not covered are provider visits, laboratory testing, and all the kind of associated PrEP care. And what's also, I think, not captured when we think about the out-of-pocket costs that patients are paying is the complexity of this system. So clinics have now hired PrEP navigators to help patients figure out how they're going to pay for PrEP. And just that complexity itself, we saw in our study at Kaiser, where we surveyed patients who've recently contracted HIV. Just the complexity of the referral process and trying to figure out how they're going to pay for it is a barrier in itself and was a reason why people did not take PrEP. Just recently, there was the approval of Descovy, which is a related medication manufactured by the same company. And Gilead has really pushed hard to argue that Descovy is a safer and better drug. So we have kind of pushed back on that a bit, both in the lay press and also in the Annals of Internal Medicine. We tried to take a step back and objectively compare these two medications, TDF-FTC and TAF-FTC, or Truvada and Descovy. Truvada has been shown to be effective in multiple populations, and we now have this robust body of evidence from a decade of use, and we know that it's safe and effective, whereas we know for TAF-FTC or Descovy that it's effective for men who have sex with men, and it was tested only in a handful of transgender women, and we don't know for other populations whether it is effective. In terms of safety, Gilead has pushed hard that Descovy is a safer drug. And in fact, they both are extremely safe drugs with minimal side effects that are not associated with clinical events for the most part. And the cost is kind of the important thing here. Truvada just went off patent last month. And so we now have our first generic on the market in the US, our first generic PrEP. And the cost is only a little bit lower than Truvada, but we think over time it is going to dramatically decrease as other generics come on the market. And so in the short term, the new generic may actually complicate PrEP access, but we hope that in the long term, as long as we can continue to keep our eyes on, the prize here, is going to increase PrEP access for people who have historically had a difficult time accessing it. So finally, I want to talk about HIV risk assessment, which is kind of the main focus of much of my research at this point. The USPSTF last year gave PrEP its highest recommendation as a grade A as a preventive medication. And as part of their systematic review, they concluded that there's a research gap. They said research is needed to develop and validate tools that are highly accurate for identifying persons at high risk of HIV acquisition who would benefit from PrEP. And the reason for this is that it's difficult for providers to identify who is at risk for HIV, and there's a lot of barriers to having those conversations in clinical settings. And so we really need automated, easy ways to help providers identify the patients who are most likely to benefit from this medication. There are some existing HIV risk prediction tools, and I'll just show you this one as an example. This is from the CDC, called the Msm Risk Index. And it's specifically for MSM, and that these tools have only been developed for MSM and one for people who inject drugs and none for women in the US. And this tool asks about age, number of partners, types of sex people have had, HIV status of partners, and meth use in the last 6 months. But these tools have some limitations. First, they require providers to know that a patient is in a risk group. So the conversation has to have already happened between the patient and the provider about the patient's sexual history, sexual orientation, sexual behavior, and those don't always happen. They're also difficult to use during busy clinical visits. You can imagine in primary care, let's say you have a 15-minute appointment, there's a lot of other things to discuss, and providers don't tend to think that their patients are necessarily at risk of HIV. These tools are only moderately predictive. They don't do a great job of distinguishing between people who will and will not go on to acquire HIV. And perhaps most concerningly, they underestimate HIV risk in Black MSM, who are at the highest risk of acquiring HIV. And the reason for this is that the risk in Black MSM is driven more by network factors than it is by these individual level behaviors. So it becomes much more difficult to measure in a simple tool like this. So the long-term vision of my research right now is to use electronic health records to try to prompt discussions about PrEP and primary care and prompt PrEP prescribing to patients who are most likely to benefit. And so I'm going to give you kind of the vision here. This is the prompt dashboard, which is shown at the Kaiser, in the Kaiser EHR for every patient who walks in the door. The physician sees this and it prompts them to make sure that the patient is up to date on various preventive services. And this patient is being flagged because they are at elevated cardiovascular risk. And this is calculated in the EHR based on all the data that are already entered into the patient's clinical history. And the provider is prompted to have this discussion. And not only that, they're given decision support tools to have this discussion and prescribe medication. So the vision here is you could have a row on here for sexual health or for HIV specifically that flags the provider if the patient's clinical history suggests they may be at elevated risk for HIV, and then actually walks them through taking a sexual history and prescribing the medication as appropriate. So the first step to doing this is to create a prediction tool using EHR data to identify patients who are at higher risk of HIV and may be good candidates for PrEP. So we did this at Kaiser in Northern California using 3.7 million members and their electronic health records. We developed and validated a machine learning model to predict incident HIV diagnosis in those patients. And here I'm showing the ROC curves for the full model, which is that top purple line, and some simpler models we created that had only MSM status as far as we could tell from the electronic health record and STI-related variables, positivity testing and treatment. And the best possible model is going to reach the top left corner of the graph, which maximizes sensitivity and specificity. And then that diagonal line, the dashed line, is no better than a flip of the coin. And what we found was our full model, which incorporated lots of different data domains, demographics, diagnoses, where patients lived, laboratory test results. That ended up being the most predictive model, whereas these simpler models got closer and closer to the diagonal line. And perhaps the most commonly used way to guide PrEP use in clinical practice is if a patient has an STI, let's talk to them about PrEP. And that was our poorest performing model, actually. And notably, the simpler models were particularly, they performed particularly poorly for Black patients, whereas we saw that our full model was equally predictive for Black and non-Black patients. And so that's actually consistent with what we know about individual level behaviors not being fully predictive of HIV risk in Black patients. And I'm going to be talking about this at NAID on Thursday. I'll be diving more into this study and this work if you're interested in hearing more details. I'll also mention that our model totally failed to predict HIV risk in women. It just didn't. And that may be because 90% of the HIV cases in our study population were in men. But it may also be that it's not possible to predict HIV risk in women using EHR data because their HIV risk is driven by the risk of their partners. So it's really difficult to measure with their own risk factors. So we're exploring this in an R01 supplement, which is led by Christine Dellendorf, where we're using data from public health clinics in Florida, where there's much higher HIV incidence among women, to try to understand whether we actually can predict HIV risk using EHR data for women. And this is an important question because there really are no tools to help guide PrEP prescribing for women in the US. So when we published this study on our model, I published this alongside Doug Krakauer's study, which was a parallel study done independently that explored the same question. And the New York Times picked up our two studies and said, would you want a computer to judge your risk of HIV infection? And they really took this angle of concern around privacy and the sensitivity of this data. And going back to Susan Buckbinder, what she asked about the at the time of the FDA advisory committee hearing, would you be asking this question about statin use? And the answer is probably no. But we do think that it's important to incorporate qualitative research into everything that we do with this kind of tool, because it does have potential unintended consequences. And we want to make sure that we're implementing clinical decision support for PrEP in a way that is sensitive to patients and also feasible and practical for providers. So that's now a part of every implementation project we're doing on this. Is qualitative interviews to try to understand, the feasibility, the acceptability, and ensuring that we're doing this in a way that is sensitive to patients' needs. So I'll just mention briefly a couple of these implementation projects. One is funded by NIAID through 2 supplements to the Centers for AIDS Research. And this is part of the federal Ending the HIV Epidemic initiative. We're focusing on Alabama, which is one of 7 hotspot states in that initiative, and specifically on Jefferson County, which diagnoses the most HIV cases in the state, and that's where Birmingham is. And the county has 3 primary care clinics and 1 STI clinic with 17 years of EHR data, but very little PrEP prescribing. And so they actually heard about our work and approached us and said, we have all this EHR data and so little PrEP going to our patients. Can you help us use our data to try to prompt PrEP prescribing? And so we're actively working on that now with them. And then we're also working on a pilot trial in community health centers. And this is funded by an R34 from NIMH. And we're collaborating on this with OCHIN, which is a national network of community health centers based in Portland, Oregon, that has a centralized EHR. And so they really specialize in these EHR interventions. They serve 2.8 million patients across the country, a fairly diverse group, racially, ethnically, and in terms of socioeconomic conditions. And they have 155 clinics in HIV hotspot counties. So the long-term vision here is if we can, in our R34, demonstrate feasibility, acceptability, and hopefully some preliminary effectiveness of a clinical decision support tool to prompt PrEP prescribing, that we could then test this in a much larger cluster randomized trial in OCHIN clinics across the country. So I'll just end here with some key points. First, PrEP prevents HIV, promotes sexual health, and connects people to primary care. So, there are robust individual level benefits, and at the same time, uptake has been limited because of cost, stigma, structural racism, and challenges with HIV risk assessment, among other barriers. We need to mitigate these barriers if we want to achieve the population level impact of PrEP and achieve equity in the HIV epidemic. Ultimately, we have the tools to end the HIV epidemic. We just need to deliver them better. So I want to end here with a few acknowledgments, not just to my mentors and to my NIH support, but also my wonderful collaborators on this work, particularly Doug Krakauer, who's my co-PI on several projects. And also acknowledge my family, who has been really supportive and patient as I've been working on all this research over the past few years. And finally, I wanted to show you this image to kind of bring this full circle. Thinking about that image from a public health campaign in the early 80s, a bad reputation isn't all you can get from sleeping around. This is where we are today with public health messaging for HIV prevention. This is the PrEP for Love campaign, which really centers what matters to patients about PrEP. But that's a message that we can bring well beyond HIV and bring to other aspects of public health, including the COVID pandemic, which is something that I've been writing about at The Atlantic. And I think that's it. I'll just end there. I look forward to hearing your questions, and thank you so much for your attention today.
Thank you, Dr. Marcus. Thank you very much for your presentation. We've had questions streaming in for quite some time, so I'll move very quickly to starting to ask them. Early on, you showed a slide that showed what a 44% reduction in incidence of HIV with PrEP in a clinical trial, and then pretty quickly you showed data suggesting that it was 99% or almost 100% effective in clinical practice. Why such a huge difference between clinical practice and the trial?
Yeah, that's a great question, and I sort of glossed over that a little bit. But the main difference there is adherence. So the 44% estimate was an intention to treat analysis that looked at just treatment group people had been randomized to. And it turned out that people had been reporting they were quite adherent to the medication, but in fact, adherence was fairly low in that trial and in several other PrEP trials that had been done at the time. And so that raised a lot of questions about how adherence was going to look in clinical practice. And adherence has typically been higher in clinical practice. People are motivated to take the medication. They know it works. They know they're not getting a placebo. There are groups who do struggle with adherence. So that is an important focus of ongoing research. And I'll also mention that 99% estimate is with optimal use. So that assumes that people are taking it daily. So those are not necessarily directly comparable, the 44% and the 99%.
All right, thank you. That helps clarify it. You noted that PrEP users did much better in other areas like getting a flu vaccine or getting screening for tobacco use or getting screening for diabetes. Did that apply across racial and ethnic groups? Was that mostly in white males? How did that pattern play out?
Yeah, so that data was from Fenway Health, and most of those patients who are served at Fenway Health are men who have sex with men and mainly white. So it's not a very generalizable population. That was kind of the first step to exploring that hypothesis, and definitely an area for more research and more diverse settings.
One of the main points of your presentation is that most of the people who are eligible for PrEP don't get it, and often used the least by the people that need it the most. I'm interested in prevention research quite generally, and that pattern is quite parallel to what we see for many of the leading risk factors for death and disability in this country. The people that need to address those risk factors the most often aren't getting the care that they need, or often aren't taking the steps that they need. You argued that it wasn't just access to care. What are the drivers here? What can we do about it?
Yeah, I mean, I think that's the drivers are so structural, and it really highlights the need for an equity approach to public health. And what I mean by that is doing more for people who need more. We can't just have a blanket approach that assumes that everybody has equal access or is in a position to make the same kinds of choices about their care or risk reduction. We actually have to do more for certain people if we want to see equity and make sure that our prevention tools are reaching people who need them the most. One of the main barriers, I think, in the HIV epidemic to prevention is structural racism, and we also see that playing out during the COVID pandemic. I mean, this is not it's not news. It's something that is pervasive in our society and really shapes how these infectious disease epidemics play out. And so our response, I think, has to be guided by that. And we have to recognize that risk is not homogeneous, that there are subgroups who are at far higher risk and have less access to services. So we have to work harder to reach those groups.
Yeah. I thought of the racism issue when you were talking about risk compensation and noting that providers appear to see risk compensation as a reason for not prescribing PrEP to high-risk groups. And I wondered if that was just racism coming through. Is that pattern apparent in both Black and white providers? Has anybody looked at that?
Oh, so that's an interesting question. So you're asking whether the race of the provider affected those biases, and I am not sure from that particular study if that's been explored, but certainly others have explored the concordance between patients and providers in terms of race and how that affects care. And that research strongly suggests that we need to ensure more diversity among providers, that will actually improve clinical care. But yeah, in the research I talked about today, certainly there was, those racist stereotypes actually made things worse. So there was this existing stigma around PrEP, around HIV, around gay male sex, and then that is compounded by racist stereotypes.
Related to that, one of our viewers asked, could you discuss your perspective on how medical providers can adopt a constructive, non-stigmatizing, non-shaming approach when discussing PrEP adherence with their patients? Yeah,
I mean, in general, I think there's a lot of important work going on trying to give providers guidance on collecting data around sexual orientation and gender identity in a way that's sensitive and consistent, around using language that is non-stigmatizing in these interactions. And from our own work, from the qualitative research we've done, we've seen that actually this can go both ways, that when we interviewed people at Fenway, some people felt stigmatized in the sense that they felt that providers did not think they should be on PrEP, and others felt their providers were pressuring them to be on PrEP. And so all of this kind of points to the need for a shared decision-making approach and non-judgmental approaches to discussing sexual health and clinical care. And so that's part of our motivation for starting to work on this grant. That would be developing an intervention that could be integrated into residency programs across the US, with the goal of really shaping the PrEP prescribing capacity and attitudes of the emerging PrEP provider workforce.
Is there a role for pharmacists?
In PrEP prescribing? Absolutely. There are pharmacist-led PrEP prescribing programs across the US. It's not something that I work on directly, but 100% there is a role for pharmacists here. And actually in California, you can now receive an initial PrEP prescription over the counter from a pharmacist. So there are efforts to kind of move this out of the purview of just ID specialists, and certainly get it integrated into primary care, but also pharmacists can definitely be leaders in this as well. I think as much as we can normalize PrEP and demedicalize it, the more that we will increase access.
Have there been community-based interventions that have been implemented or being developed to address barriers to PrEP? That would get us outside of relying on ID docs and primary care.
Yeah, absolutely. My work has focused mainly on clinical settings and on, increasing PrEP uptake in that context. But of course, that assumes that everybody's walking in the door to see a primary care provider, and so that's only going to address a certain segment of the population. And we also need to reach people who are not ever going to walk in the door. So yes, that work is ongoing. It's just not my area of research specifically.
Do we have any data on long-term health effects of these drugs on non-HIV patients?
Yeah, I mean, at this point, now that PrEP was approved in 2012, we now have really long-term data, and we recently have looked at that at Kaiser, where we now have people who have been on PrEP for many years. And we continue to see really good safety and good effectiveness long-term. We're not seeing breakthrough HIV infections for the most part, and people are consistently taking PrEP. It is something we need to continue to monitor as people are taking it long-term, because there are, at least for Truvada, there are side effects in terms of bone health and in terms of kidney health. And although those have been minor to date for the most part and not associated with major clinical events, it is something we need to continue to monitor. And with Descovy, we also need to continue to monitor safety long-term, because we do see some side effects there as well, just a different side effect profile.
Do we have long-acting injectables yet?
So that was like some of the most exciting news for HIV prevention over the past few months, that we do now see studies coming out showing efficacy for long-acting injectables for multiple populations. So that's a really exciting new development. And for women, actually, this just came out last week, we see higher efficacy of long-acting PrEP than we do for daily oral PrEP, so substantially higher. And that may be, again, going back to adherence and the challenges that some people have in taking a daily pill for various reasons. And so that could really be a game changer. And I think, I can't anticipate when approval will happen, but I think over the next few years, there's going to be a lot of really interesting and important implementation research focused on how we're going to bring long-acting PrEP to scale in the US and more broadly.
So what are the opportunities or challenges for getting long-acting injectables out there?
Well, I think that there's an obvious benefit in the sense that it's not something that needs to be taken every day. On the other hand, it's not something that can be delivered, let's say, through telemedicine. Somebody has to come into the office and receive an injection every 2 months. And there may be people for whom that is more challenging than daily PrEP. And so I think whether we will see a population level impact is going to depend on how many people who are not already taking daily PrEP and don't want to take daily PrEP are really excited to take long-acting PrEP. And some of those populations may be populations that have really just been unable to have high uptake of daily PrEP. Let's say populations who are experiencing homelessness, people who use drugs, where adherence challenges are more difficult, but there is really, often for some of these populations, there are touch points with the healthcare system, let's say for substance use treatment, where you could integrate long-acting PrEP. And so I think those are the questions that are going to need to be explored in implementation research moving forward.
What do we do about public policy barriers? We've got a note here from someone who works in South Carolina and says that county public health departments are prohibited from offering PrEP. If that's accurate, that would seem to be a huge barrier.
That does sound like a huge barrier. It's not something I have heard before. I mean, there are certainly public health departments that are very active PrEP providers, but if there are barriers at that level, that is something that needs to be addressed. And I think something we've learned over time in the HIV epidemic and in other areas of public health as well, and I think something we're relearning in the COVID pandemic, is that relying on individuals to make certain choices and change their behavior and come into the doctor's office of their own accord, just relying on individuals is not enough. We have to be thinking about structural interventions and these policy decisions that are going to have a much broader impact than simply making a recommendation to people to change their behavior. And so I think that's increasingly been evident and recognized in the HIV epidemic, and there's now, I think, more of a focus on those structural barriers. And so I hope that's something that will continue to be a focus, especially with the federal Ending the HIV Epidemic initiative.
I couldn't agree with you more. Relying on individual behavior change models is not going to get us where we need to go, and often environmental or policy level interventions are both less expensive and far more effective. A question looking forward. 99% effectiveness is really remarkable, especially for an approach that doesn't involve a vaccine. We tend to think of 95, 99% as something that we get out of a vaccine. But the flat line in HIV incidence in recent years points to the issue of dissemination of a very effective preventive measure. We're just getting news in the last 10 days that we've got 2 vaccines that are coming out for COVID that are in the 95% effective range. But if we don't have much uptake, that's not going to help. What does the experience from your work from the HIV field have to offer for the country as we're looking to the dissemination, implementation of the COVID vaccines?
Yeah, I would say just broadly, taking this talk and layering it onto the COVID pandemic, I would say people who think about implementation in their everyday research are really thinking about that with the COVID pandemic. So let's say, there's vaccines, there's also, let's say, masks. We tend to focus on these interventions as magic bullets that will, if we all just did this thing for X number of weeks, this would go away. If we all got the vaccine, this would go away. But it's never that simple. There's always implementation challenges that, it's the first step to develop PrEP. It's the first step to find an effective vaccine. And then there has to be work poured into implementation and equity and scale up. So I think if we learn anything from HIV, it needs to be that we have to have an equity approach. We have to be thinking about implementation, but it's never as simple as, just everybody wear a mask and this will go away.
As a last question, we have someone who's just getting into their PhD program at Columbia, interested in working in this area. What advice would you offer for someone who's just getting started and interested in this content?
I would encourage them to contact me, and I'd be happy to talk with them and provide some guidance about who to talk to. But this is, to me, my bread and butter. I love this. I'm so excited to be able to work on this every day, and so I definitely encourage them to explore their interests and happy to engage.
Great, thank you. I want to thank you, Dr. Marcus, for a terrific presentation. I want to thank our audience for so many good questions and a lively discussion, even if it was via chat and not over microphones in a conference room. As I mentioned earlier, we will be posting the slides and a recording of today's presentation on our website next week. Everyone in the audience will get an email with a link of so that you can access the slides and recording. Thanks everybody for joining today's lecture, and thank you again, Dr. Marcus.
Thank you so much.
We'll sign off.